Okay. First, I would like to thank Dr. Ashwad and Dr. Fouad Sabatin for the kind invitation. And I will be talking about the role of adjuvant chemotherapy in colon cancer. It's really a big topic, but I will try to go over a few questions. So the first one, should patient with stage 2 colon cancer receive adjuvant chemotherapy? What is the role of MSI testing in adjuvant setting, and what is the intake? And the burning question over the last year in stage 3 colon cancer, 3 versus 6 months, what is the optimal duration? So this is just an overview about the development of chemotherapy in colon cancer. And as you can see, over 40 years, we've been using the chemotherapy with different treatment intent. Initially was for palliative chemotherapy. Then in early 90s, we started to use it as adjuvant chemotherapy. And recently, the concept of neoadjuvant chemotherapy has emerged. There has been many approval for many agents, and this is mainly in the metastatic setting. We have biological agent, we have chemotherapy, we have oral agent, and in metastatic setting, we know how to combine this medication and how to sequence them and who is going to benefit and who is not. But when it comes to the adjuvant setting, we have a limited option. So we have 5-FU, capecitabine, oxaliplatin in combination with the above, and in Japan and some area in Europe, they use S1 as adjuvant therapy. So this is the timeline. This is the timeline how the adjuvant therapy in colon cancer developed. So as I mentioned, in early 90s, the 5-FU and letrozole, which nobody's using it nowadays, both in the adjuvant setting. Then with time, we know that 5-FU 6 months is equal to 12 months in terms of benefit. Then we know that the oral 5-FU, which is capecitabine, is equal or superior to infusional 5-FU. And oxaliplatin has emerged around 2003 as has a role in combination with 5-FU in the adjuvant setting. And when you look to all these trials that was done in the adjuvant setting, this is an important point that they consider. Many of the endpoint of this trial consider disease-free survival as the primary endpoint. And the reason for this is, as you can see in the slide, most of the recurrence happen in the first 3 years. So many of the investigators thought that if the disease-free survival in 3 years considered as a primary endpoint, it can be used as a surrogate for overall survival. And this is also what has impacted the surveillance for patients with colorectal cancer. We follow them especially intensively in the first 3 years. Some people, they can expand the surveillance up to 5 years, but the critical period, I guess, in the first 2 years. One more point, most of the adjuvant trial was done in combination population. So you'll find most of this trial have stage 2 and stage 3 patient. So stage 2 patient, to start with, there is no lymph node involvement. It's only about the depth of the invasion of the tumor. And you can have the tumor that's involved to subserosa, or you can have invasion of the nearby structure, which is stage 2C. So when you read about adjuvant chemotherapy in colon cancer, you find frequently the word of controversy, dilemma, debate, always there. And I don't think in my presentation I will resolve this, but I will just explore with you why we have this dilemma in patients with stage 2. So if you go to the NCCN guideline, if you go to high-risk population stage 2, you can see the extreme of the recommendation. Either you observe the patient or you give 6 months of intensive chemotherapy, platinum-based chemotherapy, which for me it's a big stretch. But this is actually, it's reflecting the data that we have in stage 2 colon cancer. This is from COSAR study. This is the largest, I think, study that include patients with stage 2 disease. About 90% of patients, they were stage 2 disease. And the issue with this trial, although it showed 5-year overall survival difference of 2.9 and disease-free survival, the median number of lymph nodes was harvested. At that time, it was 6 lymph nodes. So there was a possibility of contamination of some patients with stage 3. In addition to that, they have some of rectal cancer patients who receive adjuvant therapy, and the benefit was observed and more pronounced in patients with rectal cancer. So really, you cannot make a clear conclusion with this small improvement in overall survival that chemotherapy is a standard in stage 2 colon cancer. In addition, the inclusion criteria was no clear indication for chemotherapy, so they included any patient with stage 2 disease. This is a large meta-analysis was published in 2004, looked for many of the adjuvant clinical trial in addition to meta-analysis for in the era of 5-FU. It didn't include the oxaliplatin trial. And the final conclusion of the investigator, as you can see here, there is no compelling evidence to advise the standard use of systemic adjuvant therapy for patients with stage 2 resected colon cancer. There is probably a small survival benefit for adjuvant treatment that present trial have not detected as significant. Now, if you look to the 5-year overall survival, you can see some of the patients with stage 2 disease, they have a worse outcome than stage 3 disease. So this can tell you that subset of patients with stage 2 disease, although they are early stage, but they can have worse outcome. And this would promote the identification of high-risk individual. So different expert groups, they came up with different, actually they share most of the high-risk feature. But what I want to mention here that the poorly differentiated tumor, it's not necessarily a bad prognostic sign. Actually, nowadays, in the era of microsatellite instability, we know that those patients usually have poorly differentiated histology, which convey a better prognosis. Now, T4 tumor is really a significant prognostic factor, and also inadequately sampled lymph nodes, because the risk of having stage 3 patient and you down stage them to stage 2, and you might not offer them chemotherapy. So with this high-risk population, what about adding oxaliplatin to 5-FU? So Mosaic study was one of the landmark study, the initial study that led to the approval of oxaliplatin as a part of the adjuvant therapy in patients with stage 3 colon cancer. And if you look to the disease-free survival in high-risk population that I just mentioned, it has 7.2% of improvement in disease-free survival. This is actually the initial report that was published in 2007. However, with longer follow-up, this is in 2011, there was no improvement in disease-free survival or overall survival. So with all this confusion in patients with stage 2 colon cancer, we come to the era of molecular identification of certain patients who might benefit or might not benefit from chemotherapy. And the two main driver for pathogenesis in colorectal cancer is either the microsatellite instability, which represents about 15%, or chromosomal instability. So nowadays, we know that 15% of our patients that we see, they have a microsatellite instability, which can be secondary to a germline mutation, which is the minority of those patients, or about 13% they have a sporadic MSI testing, and they have the phenotype of Lynch syndrome. So you can test for this by two ways, either looking for the protein by immunohistochemistry or doing the PCR to detect the microsatellite instability. And the feature when you see the pathology report that might suggest that this patient has microsatellite unstable tumor, usually they are in the proximal colon. Usually, as I mentioned, it's poorly differentiated, mucin producing with lymphocytic infiltration. And when you look to the percentage of patients who have microsatellite instability, usually about 20% in stage 2. And as you move with the stage, the percentage come low, as stage 4, Dr. Sabatine just mentioned, and less than 4% actually they have microsatellite instability. This tells you that those patients usually they come at early stage, they rarely metastasize, and they have a better outcome. So if we identify this population, can we spare some of our patient chemotherapy that is not indicated? If you look to the data from PTAC study, this is the study was looked for the irinotecan in the adjuvant setting comparing to 5-FU. Despite it was a negative trial, if you look to the two most important prognostic factor in stage 2 was T4 versus T3. T4 has a poor outcome, and tumor with MSI high, they have an excellent prognosis with a hazard ratio of 0.28. So this tells you that the microsatellite instability, they have a good prognostic use. In addition to that, in COSAR study, the study I just presented to you, when they looked back to their patient, they found that 13% of the patient has mismatch repair, and they have a better outcome comparing to T4 tumor, which was a significant poor prognostic factor. So and this is in terms of prognostication. Now, is there any difference in terms of response to the treatment? This is, although it's a small number of patients, but this can tell you that some of the patients with a stage 2 who has a mismatch repair deficient, in other words, MSI high, they have a detrimental effect with 5-FU. Now, this result might not be replicated in other study, but giving the good prognostic feature of this tumor and data that is coming and indicating worse outcome with the speculation. If you have a patient with a stage 2 disease with MSI high, I think chemotherapy is not indicated. So what I would say about stage 2 colon cancer, so chemotherapy is not routinely used, and it's considered a patient with high risk feature. If you have a patient with MSI high colon cancer with no high risk feature, they shouldn't receive chemotherapy because of their excellent prognosis, and the chemotherapy will not add to this. And if MSI high and high risk feature, and if the chemo to be used, oxaliplatin should be added to overcome the resistance to 5-FU. So for stage 3, I think we have more consensus that most of the patients benefit of chemotherapy. If you can see on the left side, this is in 1990 with the era of lifamazole and 5-FU. And there was a benefit since that time. And even with the recent study, we can see the one on the right side is a fluoropyrimidine-based therapy compared to observation, and there is a clear benefit in stage 3 patient. We know also that capecitabine, which is the oral form of 5-FU, is equivalent or even better than infusional 5-FU. And if you look to the Mosaic study, the data for stage 3, they have improvement on overall survival by 4.4%. And this finding was also noticed in other studies that looked for oxaliplatin as a part of their therapy. So the NSABP C07 and Zeluxa study both confirmed the improvement in disease-free survival and overall survival. So this is an important point to consider in patients with stage 3 disease. Although we say that all patients benefit from chemotherapy, but you see the benefit of adding oxaliplatin is more pronounced in a patient with more nodal involvement, more than 3 lymph nodes. And this has something to do with what I'm going to say in the 3 versus 6 month. So trying to explore more option in adjuvant setting for colon cancer, 3 negative trials for irinotecan. There was no improvement in disease-free survival or overall survival on this study. And we looked also for the biological agent, which has an important role in metastatic setting. However, 3 trials of bevacizumab failed to show any benefit, although it was given up to 12 months after completion of after surgical resection. And there was one more trial I didn't include it here, but all the trials were negative. And when it comes to the targeted therapy, everybody was excited at that time with the presence of KRAS status as a predictor of response. So cetuximab was studied, and unfortunately, it's not only a negative study. Those who receive cetuximab might have a detrimental effect by receiving cetuximab in the adjuvant setting. So for stage 3 patient or patient with a stage 2 disease who receive adjuvant chemotherapy, neuropathy is a big concern. And as you can see in this slide, it can last up to 4 years. And since we have no much debate on stage 3 colon cancer, so some of the oncologists, I think, decided to have one. So they come with the question, can we shorten the duration of chemotherapy while maintaining the efficacy of the therapy? So 3 versus 6 months, this was the discussion over the last year. They came up with the idea. It's a collaboration. It's not a trial. It's a collaboration between 6 different randomized study done in different countries, and they randomized the patient to the 3 versus 6 month with oxaliplatin-based therapy. So it was investigator choice and patient preference. And the study, it was a non-inferiority design, and the idea they came up with the statistical term that the confidence interval of hazard ratio of disease-free survival should not exceed 1.12. So the number they came up is based from mosaic study where there is disease-free survival improved by 24%. So oncologists and patient advocates met and they decide that if we can shorten the duration of therapy and not losing more than 12% of adjuvant chemotherapy will be the end point, and they choose the 1012 as the non-inferiority margin. So this is the non-inferiority margin that they used, and when they analyzed the study, the upper limit of confidence interval was 1.15. So the study did not meet its primary endpoint. Despite if you look to the curves, it look similar, but in terms of statistics and based what they define as non-inferiority, it was a negative study. So people start to look to the analysis based on subgroup and regimen. So with respect to the regimen, it was pre-specified. However, for the risk group, they classified the patient to high risk if they have T4 or N2 disease, and low risk if they have T1, T3, or N1 disease. This was not pre-specified before the analysis. And as you can see here, FOLFOX is clearly inferior in high-risk population if you give it for 3 months. And if you look to the low-risk group, they mentioned that the CAPOX can be non-inferior or even superior in patients with low-risk disease. In terms of toxicity, as expected, when you give less oxaliplatin, there was a threefold reduction in the risk of neuropathy toxicity, which is an important outcome to our patient. So despite the large size and the prospective study of the IDEA collaboration, there was no direct evidence that CAPOX compared to FOLFOX has a superiority or non-inferiority in all patients. And patients, to have a better outcome of this study, should have been randomized to CAPOX versus FOLFOX, and they should be randomized to 3 versus 6 months. And the analysis by risk group, despite it was in a good sense, but it was not pre-specified before the analysis. And the data from 3 available trials is heterogeneous. However, 3 out of these 6 trials are not available yet. But again, if you look to this slide again, some patients of stage 3, especially when talking about T1 N1 disease or T3 up to TN1 disease, they can have a better outcome of some of stage 2 disease. And this make you ask yourself whether really you should go with a 6 month of therapy in those population. So what I would say that for high risk patient with stage 3 colon cancer, 6 months of chemotherapy, whether CAPOX or FOLFOX. For low risk population, it's something to discuss with your patient. And if you will go for 3 months, I would recommend to use CAPOX rather than FOLFOX. And by this, I conclude my presentation.